So for colon cancer patients specifically, when we're looking to make the decision after surgery as to who will benefit from adjuvant chemotherapy or systemic therapy, traditionally and historically, we've looked at items such as the T stage, node positivity, lymphovascular invasion, and then later on came the MSI high, which had a negative predictive value for adjuvant chemotherapy. But all of the other items, effectively what we were looking at is a hint or foreshadowing as to whether those patients will have some minimal residual disease or cancer cells on the microscopic level. The importance of ctDNA is now we can actually measure and quantify that MRD, and we don't have to play the guessing game anymore. And studies have shown that the positive predictive value, as well as the negative predictive value of ctDNA is much, much better, and it kind of dwarfs the other markers which we historically used. So moving forward, this, I believe, will become the new standard of care when we're trying to make up our mind and help guide the patient as to whether they will benefit from adjuvant chemotherapy or they can go on surveillance. On the flip side of it, moving forward for patients on surveillance, traditionally we've only used CEA and imaging studies to try to detect recurrence. And the idea is we want to detect it as early as possible to maybe get them back to surgery and help them achieve a cure if possible. Again, with ctDNA, we can detect MRD or recurrent disease much earlier. The studies have shown that there's a lead time of about 8 months between ctDNA turning positive and then us finding some changes on CT scans. Therefore, I think it'll be very important moving forward to utilize ctDNA in surveillance. The added benefit of that as well is we don't have to subject the patients to radiation. It's only a blood test, and then if that's positive, then they will need to undergo imaging. But it helps minimize cost, it helps minimize radiation exposure and time as well.